Next is brachycephalic syndrome. This is again which we all see very commonly, which you have if you have practicing and you have got a lot of pugs and bulldogs and French bulldogs, you will definitely come across this syndrome. Where it's a combination of different problem, stenotic mass, elongated soft palate, eversion of laryngeal saccule, and tracheal hypoplasia, all sometimes all together or sometimes in combination of one or two. They always are presented. The milder ones are only having stenotic nares, and the less serious ones have stenotic nares with elongated soft palate, and some have over a period of time when this respiration becomes very bad and chronic, they suck in those laryngeal sacules and larynx inside the cavity, and they all became hyperplastic, and they all suffer from severe problems, and the dog goes in for a very serious problem. Okay, next please. So this is a a congenital malformation of this specifically this breed. It is very important that you should know these breeds are most problematic things, because they have a short and long axis. So what happens in all these things? Most of these stenotic nares, enlarged tonsils, elongated soft palate, narrowed rim of glottis, all this leads to a narrowing of the lumen. Because of that, the breathing becomes very hard, and a pet makes more efforts, inspiratory and expiratory efforts, and it is highly excited, and they go in for asphyxiation and collapse during severe episodes of this problem. Okay, this is because of a breeding problem where there's a shortened long axis, and there are several researchers have done, which is important. Cranial length to skull length, and angle between the basal skull and facial skull, all these things have been debated. Nevertheless, whenever this short nose breeds, all other things inside are growing. So they have an elongated soft palate, disproportionate to the shortened face. So these are things which make them highly prone for this brachycephalic airway syndrome. Okay. That is the reason you get. And apart from that, you have several problems in these sorts of brachycephalic problems. They also suffer from hydrocephalus. They suffer from facial nerve paralysis. They suffer from skin fold pyoderma. They have a eyeball prolapse. The skin fold touches their cornea. They always go in for corneal ulcers. They are malpositioned teeth, all because of shortened nose and a broadened skull. All these things happens. Okay. So what is the pathophysiology of this brachycephalic? The senosed nares, leads to shortened nose, increased resistance during inspiration. With the negative pressure, the soft tissue are drawn into the lumen and become hyperplastic. Secondary manifestations of brachycephalic syndrome, such as everted laryngeal sacules or tonsils, then the partial collapse of the dorsonasal pharynx, the narrow rim of glottis, and collapse of the trachea, all these things put together constricts the respiratory system much more and causes very severe dyspnea. Okay, next please. So these are all some of the skull measurements: the short and long axis, the cranial length with the skull length, with compared to the width of the skull base, and the angle made by the base of the skull to the facial skull. All these things are done to find out the severity of this brachycephalic airway syndrome problems. You can also, when the puppy comes to your restaurant, these measurements can be taken to see what the probability of that these pet going into severe brachycephalic airway syndrome. Okay, such are those cases we can start doing corrective procedures to start with. So usually the procedure starts from front to back. So if their nares are very stenosed, you can do a small surgery for widening the nares. Okay, then you can do a partial surgery of the soft palate. All those things are possible if you are able to foresee the problems in these sort of brachycephalic breeds. Okay, next please. So what are the brachycephalic breeds? Boxers, Bull Mastiff, Chihuahuas, Pekingese, Pug, Rottweilers, Shih Tzu. These are all brachycephalic breeds where the nose is very short in comparison to the skull. So they are called as brachycephalic breeds. So they are made a differentiation how based on these calculations which are brachycephalic breeds. Next please. So the clinical signs of brachycephalic, you have a stutter and stridor. As I already told you, stridors are continuous respiratory noises. Stutter are discontinuous sounds. Gagging, they always gag because their airway is blocked. So they feel as if they are choking. The productive coughing, they always have a cough where the phlegm comes. Difficulty swallowing or sleeping. Usually, most of the times, the brachycephalic syndrome occurs during sleep. So they have difficulty in sleeping because they just fall on and then those loose tissues cover the airway. They are usually presented with severe dyspnea and very bad cases, cyanotic mucous membrane because they are not able to take in the inhaled air. Hyperthermia usually is a big problem. Suffocation occurs during sleep mostly. Mostly, I told you, the problem occurs during sleep. Worsens after exercise, excitement, or stress, or with increase in environmental temperature or humidity. These are all the stress factors for or initiating factors for brachycephalic syndrome. Any stress or excitement or environmental temperature with high humidity, these are things which triggers the brachycephalic episodes. Next, please. So we have seen the pathophysiology. I already told you about the pathophysiology, how the stenosed nares, shortened nares and meanders, increased resistance during inspiration, causes negative pressure, and soft tissue are drawn into the airway, and they become hyperplastic, further stopping the airflow. Next, please. So the secondary manifestations such as everted sacules, collapse of dorsal pharynx, all these things are going to cause more and more problems in these breeds. Next, please. Next, please. So this is again a video of a small pug having a bass.
அப்படியே திருப்ப படிக்க வைங்க, மல்லாக்கா படுக்க வைங்க.
So these are all oral cavity examination where you see the elongated soft palate, you see the everted laryngeal saccule. All these things can be done by rigid scope or by laryngeal scope itself. We can examine these everted laryngeal circulation and enlarged soft palate. This is done under general anesthesia. Then only you'll be able to clearly see them. And again, anesthesia is a very, very risky thing in such a brachycephalic breeds where they have a compromise on respiration. You'll have to be very careful. That is reason it is done under live general anesthesia, where you can see, examine the soft palate, and you can see the everted laryngeal sacules. You can see the ocal folds, and to what extent these laryngeal sacules will reduce the rima glottis. That is the space where the air flows. Next, please. So the treatment, is mostly surgical. So it, as I told you, starts from front to back. First, a nasal wedge resection where you widen the nasal cavity. Okay, next is a staphylectomy. Staphylectomy is a partial removal of the soft palate. And then laryngeal sacculectomy. So the larynx also you do a sacculectomy. You can even the laryngeal sacules you can remove with the long scissors. You can cut so that they don't come in the way of the breathing. So all these surgical procedures are commonly done in very many places in India. So it should not be a very big problem for practitioners to practice these small surgeries or refer them to hospitals where they do this sort of surgeries. Next, please. For surgical correction, you will have to partially resect the soft palate, and how much you will be able to swim up to the level of the epiglottis or to the middle of the glottis. you will be able to remove the partial removal of the soft palate. To that extent, you should be able to remove them. Okay. Next, please. Laryngeal collapse. This is again a sequelae to the brachycephalic airway syndrome, or some animals who have independently also laryngeal collapse, and they are trying to find out what are the pathogenesis behind such a laryngeal collapse. They see probably they have some cartilage problem. Therefore, certain animals have yeah, flaccid cartilage, which collapses during inspiration. Okay, there's loss of supporting function of the laryngeal cartilages. Stage 1, eversion of the laryngeal sacules. Stage 2, loss of rigidity and medial displacement of cuneiform process of the arytenoid cartilage. You know, the arytenoid cartilage is the one which abducts during inspiration. Failure to abduct during inspiration will close the passage. So therefore, you get into severe dyspnea. Stage 3, collapse of the corniculate process of the arytenoid cartilages with loss of the dorsal arch of the rhizoglottis. This laryngeal inlet. A progressive end-stage disease. Laryngeal collapse is a progressive end-stage disease of the brachycephalic airway syndrome. Next, please. So, diagnosis by oropharyngeal examination, usually with the laryngoscope. So the corniculate and cuneiform process of arytenoid cartilage are opposed or overlap. Abduction of the arytenoid is not seen; it is absent. So when there is inspiration, the arytenoids fail to abduct. Therefore, the passage is closed, and therefore you have the obstruction of the respiratory tract. Next, please. So next is the laryngeal paralysis. So this is seen in middle-aged to old, large, and giant breeds. In our country, we most often see them in Labradors. It may be idiopathic or may be congenital in certain dogs like Huskies and Dalmatians, and mostly seen in other problems where you have polyneuropathy like hypothyroidism or diffuse polyneuropathy. Such are those diseases you find recurrent laryngeal nerve paralysis. It can be unilateral, it can be bilateral. Interruption of the nervation of the intrinsic muscle of the larynx, precoarytenoids dorsalis muscle, failure of the arytenoid cartilage and vocal fold to touch. This is a dynamic process during inspiration. The arytenoid cartilage fail to abduct, and therefore you get obstruction. Next, please. So you can see the cricoarytenoid dorsalis muscle, which goes upward and abducts and creating more passage during inspiration. In cases where they are flaccid, they fail, where there's a laryngeal nerve paralysis, the fails abduct, and therefore there's a narrow passage. The rhizoglottis is closed, and therefore air cannot enter into the respiratory tract. So what are the clinical signs? Again, stridor, continuous respiratory sounds, gagging as if it is choking, cyanotic mucous membrane, and most of the times synapses. During walk, they collapse, or exercise, or when they are excited, they collapse and fall down with cyanosis and gagging. So, how do you diagnose them? With the oropharyngeal examination. So, bilateral dysfunction of the CAD muscle, observe abduction during inspiration. So when it is failing, then it is laryngeal paralysis. It's a dynamic process I told you. Next, please. So the treatment, other than surgery, usually mostly surgical, surgery. But otherwise, when the first time a client comes to you, O2 therapy is most important because they suffer due to asphyxiation and choking. So oxygen therapy is very, very important. External cooling is also very important because one of the most important reasons for paralysis is external environmental temperature. So cooling helps to reduce that. Sedation, mild sedation, where there is no, it's not excited, therefore edema and all comes down. Assisted breathing, so whenever there is a problem, you can intubate them and recover from the. Then the last thing facilities only is arytenoid lateralization, where this is called a tieback surgeries. I don't know anybody is doing in India, but it's a very simple procedure. You can do unilateral or bilateral. Of course, there are a lot of complications because of that, aspiration pneumonia, secondary bacterial problem. There are so many issues with this. Nevertheless, the outcome of the surgery in case of these sort of problems are very, very good. Next, please. So that picture is missing in this presentation, where the cartilage is sutured with the surrounding tissue so that the abduction will not be there. So permanently they'll be opening. That is the reason I told you sometimes it leads to aspiration pneumonia and things like that, gagging, all those problems. Otherwise, still it is a wonderful thing to do tieback surgeries in dogs with recurrent laryngeal nerve paralysis. And the most common causes are trauma, usually thyroidectomy in case of cats. Cats is a rare disease, but still doing a surgery for thyroidectomy will injure the recurrent nerve, and it can cause problem. And any other associated problem with the laryngeal problem can cause this sort of recurrent nerve, mostly tumors. They cause this recurrent laryngeal paralysis. I already told you diseases like hypothyroidism also can lead on to problem of recurrent laryngeal paralysis. Next is tracheal collapse. As I told you, this disease affects breeds which are less than 10 kilos, mostly toy breeds, like Shih Tzu, Lhasa Apsos, Pomeranians, all these things. Refers to the narrowing of tracheal lumen, resulting from flattening of the cartilaginous rings with or without laxity of the dorsal tracheal membrane. Progressive degenerative condition. Middle-aged toy breeds, Yorkshire Terriers, miniatures, and toy poodles, Pomeranians, Chihuahuas, Maltese, occasionally congenital in young dogs. Next, please. So etiological thing predisposed in small breeds, and especially if it is obese, degeneration of tracheal cartilages, chronic bronchitis can lead on to tracheal collapse. Of course, concurrent laryngeal paralysis, 30% cases. Concurrent mainstem bronchus collapse in 50% cases are seen whenever you see tracheal collapse. Next, please. The clinical signs are stutter and stridor, dyspnea, goose honk cough. This is very, very, very characteristic. I don't know how many of you have listened to goose honking. I'll just try to mimic. That sort of sound is called goose honk. That is very characteristic of problem associated with trachea, decreased exercise tolerance, voice change. Some owners will come and tell you that the dog is changed voice or it is not barking. Such are those cases you'll have to suspect tracheal problem. Then hyperthermia, then gagging and dysphagia, cyanosis, syncope, all are seen in tracheal collapse. Next, please. So diagnosis usually asymptomatic at rest, varying degrees of coughing, dyspnea, stridor, worse during excitement, exercise, high temperature, or when collar presses on the neck. Signs may progress to constant severe coughing and dyspnea, cyanosis and syncope in severe cases. Usually the owner comes to the clinic saying their animal is having coughing, and when it comes to the hospital, the parasympathetic innervation makes it have a wide open airway, so it may not be coughing. So you just examine the dog and palpate the trachea. Immediately, you could elicit a cough response, sometimes leading on to paroxysmal goosong, sometimes only cough. Is highly suggestive of tracheal collapse. Next, please. Diagnosis unremarkable. Palpation of tracheal border sometimes help, where you can see the laxity. Cough may be elicited on tracheal palpation, as I already told you. Next, please. So radiograph is excellent. You can do the narrowing of the trachea, especially at the thoracic inlet. Radiograph should be taken during inspiration and expiration. This is what is most important. A single exposure of radiology, sometimes you may not get. So it may, become flat from dorsal to ventral or from side to side. So you require a dorsal-ventral picture as well as a lateral picture, radiographic picture to find out whether it has got, flattening from side to side or not down. So both are possible in case of radiographic diagnosis. Next, please. Yeah. Fluoroscopy is an excellent choice for this one, but very many practice may not have fluoroscopy. Tracheobronchoscopy is a gold standard, allows grading, and is best method to assess mainstem bronchial collapse also. So it's very, very important you have a bronchoscopy or refer the case to a bronchoscopy where you can grade your case. So this is the endoscopic classification where you find to what extent they are narrowed and you classify them. Next, please. So this is again a wonderful videoscopic endoscopic procedure which we have videographed. You can see the narrowed trachea beautifully. But once we are able to see this, then you can enjoy this presentation. Next, please. So grading of the tracheal collapse based on the degree of collapse of the rings and laxity of the digital dorsal membrane. It is grade 1, 25% decrease in diameter, 50% decrease in diameter is grade 2, 70% decrease in luminal diameter, grade 3, 100% decrease is grade 4, and you can see them in the picture next. Next, please. So when you have, this is the grading of the tracheal collapse. So when you grade them, this is very important for the prognosis of tracheal collapse and also to whether to treat them medically or to treat them surgically. Whether to go for tracheal rings or tracheal stent, what type of surgery, all those things, this sort of grading is very, very important. The focal reduction of the tracheal lumen. Okay, next, please. So the medical treatment, when it is not very serious, when there's only in the diameter, you can maintain them medically. Avoid airborne allergens and irritants. Example, dust and smoke. This is most important. Any person having a pet inside the house who are smokers, you have to ask them to stop smoking because most commonly that is what initiates an episode of this goosong, continuous episodes of goosong. The client smokes, immediately the smoke irritates and they have a paroxysmal cough or paroxysmal stridors. So that is minimum. Dust and dust allergy, all those things, plants, pollens, all those should be avoided. Identify and minimize the exacerbating factors like humidity, temperature, and things like that. Weight loss should be managed. Wearing a harness instead of a collar is very, very important. Keeping a dog in a cool environment and again, stress-free environment is very, very important because stress is the most important. Stress and hypothermia are the most two important things which triggers this episodes of paroxysmal cough. Next, please. So treatment, you can reduce anxiety. Then there's one online product called Rescue Remedy, which you can give, pills which you can give for dogs. Then glucosamine, which you use for hip dysplasia, that can be tried. Honey mixed in warm water can be tried 3 times daily. And you have anxiolytic drug with Oriheal. That also is a wonderful choice for this type of cases. Next, please. So bronchodilators to help will go a long way. Theophylline, ephedrins, antitussives, butophenols, hydrocodone, sedatives, azithromycin, corticosteroids to reduce airflow inflammation. Antibiotics are usually not required, but it's a secondary problem leading on to parenchymal disease or aspiration problem, which are very, very common in tracheal collapse. They can go in for antibiotics. Next, please. So this is a tracheal ring processes. See, you have got commercially available processes, or also you can make it yourself from this syringes, 2 ml, 5 ml, 10 ml syringe, according to the type of, the tracheal size. You can take them, cut them into small strips, and make like a C clamp and put them in all those collapsed areas and stitch them. Okay, this is a very simple surgery. The only problem is you will come across a lateral laryngeal nerve that should not be damaged. If you damage that, you have another case of lateral laryngeal paralysis. So that is the only concern while you are doing this surgery. Otherwise, straightforward case of tracheal ring processes can be done. Internal processes are also available, which can be kept with the use of endoscopes. Next, please. So these are all some tracheal stents which can be kept inside the trachea with the help of endoscopes, which we are doing in Madras Veterinary College, Chennai, and it is also done in Bangalore private veterinary colleges. I do not know any other hospitals in Delhi also must be doing this tracheal stents. So when you are getting cases of tracheal collapse in miniature dogs or small breed dogs, and it is tracheal collapse, and you are not able to medically maintain them, then you will have to refer them to hospitals where they can put a tracheal stent. They should have a C-arm, and such all those facilities are must for keeping the stent. Okay, next, please. Okay, so in to cap up all this upper respiratory tract disease, we'll just want to come laryngeal paralysis. You have to do arytenoid lateralization, where you tie the arytenoid cartilage to surrounding tissue so that it doesn't abduct. Okay, it's permanently kept open. Okay, laryngeal collapse. Either you do a permanent tracheostomy or combined cricoarytenoid and thyroidenoid lateralization procedure, which I have not done. So this laryngeal collapse can be done. Usually, what we do here is permanent tracheostomy. Then tracheal collapse, application of extraluminal processes or intraluminal stenting, and segmental stenosis, tracheal resection, and anastomosis. Sometimes you have tracheal hypoplasia in certain breeds, like West Island Terriers. You can have a segmental small area of hypoplasia where it dense inside. So they have a paroxysmal cough sometimes. Such are those cases where you can do a tracheal resection and anastomosis. Next, please. So now we'll come to small airway and alveolar disease. So you will see mostly canine chronic bronchitis and pulmonary parenchymal disease. Next, please. So canine chronic bronchitis, any cough for more than 2 months, you think about chronic bronchitis, or productive or non-productive cough. Cough mostly is heard on auscultation. It's deep-seated, deep-seated coughs. Mostly it's heard with the stethoscope. Sometimes deep, husky coughs. Okay. Sometimes during cough it has syncope. And physical examination, you find crackles and wheezes in the ventrocranial part of the auscultatory field. You find crackles and wheezes, prolonged expiration and expiratory push. After the expiration, you will have a small lift of the abdomen, a jerk. That jerk is called expiratory push. That means it is unable to get the carbon dioxide in the lung out, and the last minute it makes an expiratory push to push the carbon dioxide out. That is what is called prolonged expiration and expiratory push. This happens on chronic bronchitis. Next, please. So diagnosis, radiology. Radiology, of course, somebody else is going to deal with that. Donut bronchi in appearance, trans line pattern, there's hyperechoic lines, white lines, and right-sided cardiomegaly is there. And of course, bronchoscopy and collecting bronchoalveolar lavage for culture and sensitivity again is highly diagnostic. Next, please. So treatment, anti-inflammatories. Then you can use bronchodilators, antitussives, antibiotics. Nebulization is really helpful, where you can use antibiotics, anti-inflammatories, some steroids, all those things to put together, saline. All those things can be made a cocktail and nebulized along with poopage to increase the secretion. You know that saline increases secretion. Secretion is a defensive mechanism. Cough, secretion, they're all defensive mechanism. As much as we increase them, it gets to clear the airways. So nebulization with steroids, antibiotics, bronchodilators, and poopage will help these cases with severe bronchial disease. Next, please. Then pulmonary parenchymal disease. So if you see for pulmonary parenchymal disease, as I already told you, you have a shallow, rapid breathing in pulmonary parenchymal disease. And pulmonary edema is one of the most important cause. Pulmonary edema can be due to primary lung disease or can be secondary due to left side congestive heart failure. And bacterial pneumonia, extension of all the problems into the lung parenchyma can cause severe bacterial pneumonia. Of course, kennel cough is wrongly entered here. Kennel cough is a tracheal problem because of bronchoseptica, boretal microbial organism, in combination with other viruses like herpes, infectious peritonitis, all those things. Causes, other viral infections like CD, all the parainfluenza, combination with Bordetella, you get kennel cough. It is wrongly entered. I have corrected it, but again, it is wrongly entered here. Kennel cough comes in tracheobroncho inflammation. Next, please. So you have a low-pitched cough. Either you are able to hear from a stethoscope, or you'll be able to hear as a husky, low-pitched cough. Dyspnea, shallow and rapid breathing. When you look at, I told you in the beginning, when you see the breathing pattern, the chest and abdomen, the amplitude of movement is very, very shallow and rapid. So that is very suggestive of pulmonary parenchymal disease. Next, please. Clinical signs, severe respiratory distress, then coughing, increased breath and adventitious sounds on auscultation. Next, please. So I already told you, cranioventral and middle lung lobes, you diagnose as aspiration pneumonia. And when the thoracic cavity is affected, it is cardiogenic pulmonary edema. Caudodorsal is usually trauma, seizures, all those, and upper respiratory tract problems. All those things we get, findings in the caudodorsal aspect of the lungs, and diffuse an entire area, acute respiratory syndrome, or neoplasia, infiltrative neoplasia of the pulmonary parenchyma leads to parenchymal disease. Next, please. So with this, I want to cap up. You have upper respiratory tract disease, lower respiratory tract disease. Then you have pulmonary parenchymal disease. Then you have pleural space disease, which is not given in this. Pleural space disease, again, we'll deal with next time when we talk. I hope Dr. Sharma gives me some space where I can play all these videos and then start from there on. Pleural space disease. Pleural space disease consists of pyothorax, chylothorax, hemothorax, all those things. So which is again very, very important for practitioners, and how to do paracentesis, thoracosynthesis, all those things I will deal in the next class. Any doubts, you please feel free to ask me. I'm very